You can.
Yeah.
Good. Okay. I'm recording this session, so obviously anybody who wants to look at this at your leisure, then please, if you get in touch with the head office, they'll be able to send you a link to the recording that's in the cloud. Now, what we have noticed is that some of the recording quality isn't that good because we're dependent upon Zoom for this. But hopefully it's enough for you to run through it and then stop at a particular slide you want to see something of and check. Although sometimes the audio quality is a bit woolly. Okay, so platelet-rich plasma, PRP versus prolotherapy. There's one underlying central principle of both of these things, and that is that they are designed to drive healing. So they're an opposite, if you like, of things like steroids, because steroids work in a different action. Steroids, to a certain extent, they slow down healing. They slow down the inflammatory response of the body. And let me just play with this a little bit. Okay. But the underlying principle is the human healing cascade, the sometimes called the inflammatory response, which was something that was noted by physicians over 2,000 years ago. And there was a Roman physician that we'll look at in just a moment. Well, we'll look at a couple of Roman physicians, actually. But one of them, certainly, he identified this healing cascade that we talk about. So both of these therapies that we're going to look at are designed to stimulate healing. They're designed to drive healing. And they're also designed to modulate an inappropriate healing response. We're all familiar with inappropriate healing responses, where, for example, you have an autoimmune disease, or where a healing process becomes stuck and it just becomes a chronic system that's going on and on and on and on and on and dragging on, whereas really it should be, perhaps if it's in response to an injury, it should be an acute response that does the job that it needs to do and then carries on with remodeling and all the other things that the immune system does, and then it stops. But you can get this inappropriate chronic situation developing, and both of these therapies can kind of jerk the proper response back to life. And they can be used for traumatic injuries or wounds. They can be used to help musculoskeletal injuries. They can stimulate growth and repair. But they are, as I say, the opposite of an anti-inflammatory. The inflammatory response that we often talk about, it was first stated in Latin, and certainly for a number of years, certainly back when I was training, we still used quite a bit of Latin in chiropody, as we called it then. We didn't call it podiatry then, so you can tell how long ago that was. But we learned calor, dolor, rubor, tumor, and functio laesae, which is heat, pain, redness, swelling, and loss of function. The first four of those, the calor, dolor, rubor, and tumor, were actually described by the Roman physician Celsus in the 1st century. He didn't seem to describe loss of function, but maybe in those days they didn't let people have loss of function. They told them to get on with it anyway, but we're a bit more caring in medicine now. Now, in order to understand both of these therapies, you need to have a passing familiarity with cytokines, also known as growth factors. And what cytokines are, they're messenger proteins. Now, we are, as we all know, a walking protein factory. Essentially, it seems the function of our body is to make various proteins, structural proteins, repair proteins, etc., but also messenger proteins. And these messenger proteins, they're released by cells that are damaged or cells that are recruited into the body's healing response. And what they do is they drive and they mediate and control the body's healing response, or the healing cascade, as we often call it. These growth factors, these little messenger proteins that are expressed by cells, they have some quite fascinating actions. So if you have a cell sitting there minding its own business, let's say that we, excuse me, I'm just going into the waiting room again. There's some latecomers here. Admit all. Right. There we go. So we've got some more there. Getting close to capacity here. Anyway, let's imagine a cell sitting there minding its own business. Let's say a fibroblast. Fibroblasts are a good example because one of the functions of fibroblasts is to manufacture a protein in the body, the structural protein collagen. Now, collagen runs through virtually everything that we do. It's a strong structural protein. And of course, if somewhere is injured, then the body needs to make more collagen to heal the injury. Or if it was in a cosmetic situation, which really podiatrists are not really interested in, although maybe some of us should be, the more I look in a mirror. But you can use collagen to rejuvenate, to re-stimulate tissue to a certain extent. Some people have it injected into their face, under their lines and their wrinkles and so on and so forth to plump up the tissue. But it's a very important structural protein. So you've got this little cell there sitting there, this little fibroblast, and it can do some remarkable things using messenger proteins. Some of the messenger proteins can have an autocrine action. So the messenger proteins that this cell makes can actually act on itself, which I know seems counter to logic, but it can do. We call that an autocrine action. The messenger proteins that it makes can have a paracrine action. Now, a paracrine action is where these messenger proteins talk to adjacent cells and tell adjacent cells to do something or not to do something, as the case may be. Have an endocrine action as well, so they can act on distant cells way away in other parts of the body. And remarkably, one cell can do all of these things at the same time sometimes. So you can see that a simple cell is a remarkable piece of equipment. These cytokines, we've only really been familiar with them since the 1950s, because in the 1950s there was a researcher called Levi Montalcini, and she was looking for a reason why certain cells seem to be driven to do certain things. And she was particularly at that point in time, she was looking at nerve cells. And she, in her researches in 1953, 1954, 1955, 1956, I think they went on, so there were long researches, initially working by herself, and then she was joined by a chap called Stanley Cohen. And between them, they isolated what they termed nerve growth factor. And that was the very first cytokine that was isolated in modern research. That's why initially these cytokines, these messenger proteins, were called growth factors. So the first one was nerve growth factor, NGF, as we call it now. They were eventually, for this remarkable research on which so much of a huge science, they were eventually given a Nobel Prize, but it wasn't until 1986. So I don't know what the delay was, but it was a very well-deserved prize that they got in the end. Interesting. So, there we go. Oh, computers never do what you want them to do when you want them to do it, do they? Right. If we look at normal wound repair, normal, healthy wound repair, let's say you've got a cut. So you've got early phase inflammation, that lasts anything between 0.1 to 3 days. You've got late phase inflammation, 0.3 to 10 days. And these are approximate figures, of course. You've got granulation from 2 to 20 days. And then you've got the reformation of the matrix, collagen matrix, essentially in structural tissue. Then you've got the remodeling, and that can go on for a year or even more. But that's normal wound repair. And really, each of those phases should happen and then stop. But as I said at the beginning, sometimes that doesn't happen and stop. Sometimes it goes on. And that's when a therapy such as platelet-rich plasma or prolotherapy can help, because it reminds the body what it should be doing. It aids the body in a healing cascade. Now, cytokines, these growth factors, they can be good, they can be bad, or I don't know if they can be ugly because I've never seen one, but they can have various reasons for their production and also various durations. Some of them have a very, very short duration. They kind of appear and then they go. Some of them have a long-acting duration. Very often, the short duration ones are the ones that are predominantly involved in the healing cascade. So sometimes you can have a situation where the healing response stops producing some of the cytokines that it should be producing. So that's when it needs kind of a kick up the backside to get it going again. First, if we look at platelets, they're a pretty good thing to look at, because these are involved in the platelet-rich plasma naturally. Now, they're these plate-shaped blood cells, and they have very important functions to do. They're a hemostatic agent, so they can control bleeding in a wound. They can form a scaffold for tissue repair and remodeling of tissue. They're a very, very concentrated source of growth factors. And they can be a binding agent for stem cells. And stem cells really are part of what we're talking about, although that's more modern research and it's quite a complex area of research that we won't get into at the moment. Plus, stem cell therapy is probably not appropriate for the kind of stuff that we're talking about, most of which happens by an appropriately trained person in primary care situations. Platelets are relatively well scattered in whole blood. And the idea of platelet-rich plasma, as you can imagine from the name, is that somehow you take these things that are very useful in a healing situation and you concentrate them. So you make a plasma, which is the liquid component of the blood, that's got a high concentration of these very important healing cells, and you set it to work in a particular area of damage or injury. Can I ask my three co-presenters, Bev, Caroline, and Gaynor, how's the chat going? Because I haven't got a chat box at all up here.
Yeah, we're fine.
Everybody's
Everybody's
Yeah.
silent. Okay. Well, it's not a bad thing. Not a bad thing. Okay. So, platelets, fascinating things, multiple reasons for their existence, but sometimes we don't have enough of them, and that's where platelet-rich plasma comes in. And its preparation, which, as I say, is usually done in a primary care situation, so we can do it in a well-equipped podiatry clinic. We can do it obviously in a hospital situation if necessary, but usually you'll do it at point of care, which is why it's so useful. So the person who's been trained to do this will take a sample of whole blood, and any training course that teaches people how to do platelet-rich plasma will include how to take blood, which is a relatively simple thing to do, because we're only taking blood for one reason here, and almost invariably you'll take it from the antecubital area here, so that would form part of the training. And do you know, we've still got people coming in. I know it's a chat. There's a chat, but as I say, I can't see the chat box. So if anybody's saying shut up, Martin, I can't see it. All right.
No, we're just getting greetings from everyone who's joining us.
Greetings. I suppose I should. Yeah. Live long and prosper, you know. You Trekkies out there, live long and prosper. Anyway, you take a sample of whole blood, you take it in a collection tube. I mean, this is something I've seen Gaynor do many, many times, and she's really good at this. Gaynor, did you actually do phlebotomy as well as a separate thing at some stage, or am I thinking of somebody else?
Years ago with you, Martin.
Oh, it was only with me, was it?
It was.
You took my blood. Was it my blood you took?
Well, it was a long time ago, but we took a variety of people's bloods. Yes, yours was one.
Do you know, I reckon it was about 15 years ago, wasn't it, Gaynor?
Something like that. something like that.
Oh, we've been together,
I know.
man and child.
Many years.
Many years, oh dear.
Many years.
I had a
Oh,
blood
good.
sample taken yesterday, actually, at my local doctor's practice, because they keep an idea on they keep a review on my prostate that men inconveniently have, and it was taken by a very, very new registrar. So the phlebotomist wasn't working, so it was one of the registrars that got in the practice, because it's a teaching practice, a very good practice as well. Oh God, he was nervous. He was absolutely terrified. His hand, as he approached me with a vacuum cleaner, his hand was going like that. I said, "It's all right, calm down. That's the vein." But nice chap. We got some blood out of him in the end.
Taking your own blood is more of a problem.
Yeah.
You know, I've never had the courage to do that.
Have you not?
It was bad enough when I cut my hair. Heavens above. I mean, look at the mess I made of it. So, you know, I was right to be nervous. Anyway, back to this. Otherwise, I'd be yattering on all day. Anyway, you take a sample of whole blood. You take it in a normal vacutainer tube, but it's not a normal tube. It works like a normal tube, but they have to be a vacutainer tube that is prepared for in vivo use as opposed to in vitro use. In vivo use means that it can be used for essentially into a human body, so it can be used in a living body situation. Whereas in vitro use is just when you take the blood in an appropriate sample tube, and it's only going to be examined in laboratories. Because obviously there are additions put in these tubes, ACD, anticoagulant and stuff like that. And some of those you don't really want to inject back into the human body. So as I say, it has to be a specially prepared tube, and it has to have a little dam in it as well. Because quite fascinating, when you actually then put that tube in an appropriate centrifuge and you spin it, you have a thing that looks like a little blob of dried wallpaper paste at the bottom of the tube. And as you spin it, it goes counter to gravity and moves up the tube. And you end up with a tube, and I should really have had one here, but I haven't got any blood in it anyway. You have a situation where you have a great big lump of the cells that you don't want at the bottom of the tube with this dam on top of it. Then you have a fairly clear solution, which we call the supernatant, because it's been spun. That's quite rich in the cells that you do want, the platelets. And essentially what you then have to do is, by various additional spinnings and what have you, you then concentrate this platelet-rich plasma even more. So you might have a vacutainer tube that's kind of filled with blood up to there, and you might end up with some liquid that is the actual platelet-rich plasma that's about that much, but that's concentrated goodness. That is concentrated gold. And I saw you sneak in, Tony. Hello. You're muted, so you can't insult me back. But you can chat if you want. But anyway, welcome, Tony. 25 minutes late. Oh, I'm surprised at you, Mr. Monday. Anyway, this thing is also known as the vampire treatment, as I say, which I think is it's a bit sensational, isn't it? I mean, what do we think? I mean, you know, Gaynor, Caroline and Bev, do you think that's a good way to describe it, the vampire treatment? Do you think it might put people off?
Yeah.
I think it's just a marketing ploy, and I suppose it's been around for quite a long time. You know, aesthetic treatments. I don't know. I don't think that will put people off, actually, Martin. I think it's become. It probably isn't appropriate for our treatments, but it's just a sensationalized way of getting a marketing tool over, I suppose.
Yeah, I suppose so. I mean, you often see that in the Daily Mail, don't you?
Mm.
You know, when they're not insulting and criticising podiatric surgeons, they're usually talking about vampire treatments. They
Well, the
really
interesting. Sorry, Martin. The interesting thing right now is that they're using plasma during the COVID-19 as a hopefully to try and get
It's
people.
part of a treatment, yeah. I've just wanted to raise what Kirsty brought up, was that vampires take it, but they don't give it back. So if we can take that for what it is.
Yeah.
And obviously don't use two holes in your body, just the one. But
Well, this is quite true.
the other thing is there is a vampire disease, which perhaps it could arguably be misconstrued that that's a treatment for that particular vampire disease, as it's called. I won't go into any diagnosis on all of that, but as Gaynor was alluding to, a lot of treatments could be arguably be called vampire treatments because they do use plasma proteins to enrich blood in necessary cases, and or for hopefully treatments of antigens, vaccines of sorts. So yeah, it's a miracle, like you said, Martin. It's laced in gold. It kind of looks a little bit that way sometimes if you look at it anyway.
It is.
Strangely enough.
I was very interested to hear Gaynor say that it's being used in COVID.
Yeah.
That's quite interesting.
With good results, with excellent results right now. It's very early days, but great results.
So are people queuing up at your clinic to be vampires?
No, that would be good, wouldn't it?
Yeah, it would be good, actually. It would be good. Okay, if we actually look at, well, I can advance that. Right. If we look at typical levels of what happens to various cytokine levels in blood versus platelet-rich plasma, then these are typical levels that increase in platelet-rich plasma because, as I said, one cytokine can recruit another cytokine, so you're making quite a cytokine cocktail. If you look at platelet-derived growth factor, then there's a 5-fold increase of this important cytokine in PRP versus whole blood. If you look at transforming growth factor beta, there's a 3.6-fold increase in platelet-rich plasma versus whole blood. And if you look at vascular endothelial growth factor, there's a 6-fold increase in platelet-rich plasma versus whole blood. The VEGF, vascular endothelial growth factor, is basically what will promote angiogenesis. It will promote the formation of new blood vessels, which sometimes can be a bad thing if it's in the middle of a tendon. We don't want angiogenesis. But in other areas of the body, in a healing situation, in tissue that's been damaged, it can be quite handy. And everything nowadays, this has been going around for so many years, that while, of course, as with any therapy, it has its adherents and it has those who don't believe in it, it's absolute rubbish, and all the rest of it. But there has been a lot of good research in this. Now, I know actually you, Gaynor, you sent me some very, very good research on this. It was a year and a half, 2 years ago. Can you remember that? No, it's gone. Yeah, but you did anyway. And I read it, just to let you know, I read it, and it was really, really good.
But, you remember it more than me, Martin.
I would always read what you sent me, Gaynor.
Thank you. What was that? I mean, there is so much research out there.
Yeah,
and
it was the outcomes. I mean, the outcomes of it. And as you rightly said there, if you put a request for research into Google Scholar or any other various things that you're using, you will be inundated with research on it. And of course, it doesn't work in all cases. Nothing works in all cases. Even if you shoot somebody through the head, it sometimes doesn't work and then they don't die. But most of the time they do. And it's the same with this. Most of the time it appears to work. That's just one example of research that I put on there, which actually struck me quite well when I read it. And here's some more as well. And once again, this is fairly good research looking at it. There is more recent stuff on top of this as well. So it's there if you actually want to research it and decide whether this is something that you think would be appropriate for your patients, something appropriate to do. The actual equipment for it is relatively simple. As I say, first of all, you need to be able to do the training on it. Now, the training is available to registered practitioners who have at least local anaesthesia injecting rights. And really, that's all you need to get on a training course for it. And then obviously you need to invest it in a little bit of equipment. So you need a centrifuge, and you need the various kits that once you're trained, you can actually get hold of from the suppliers. Gaynor, can I ask you, do you still use the full kit, or do you just use the tubes?
We still haven't standardized this, Martin, because we were talking at the end of last year of trying to standardize the PRP treatments within the Institute, because I still use Dr. PRP. So I tend to use the tubes, although sometimes if I'm only injecting into tendinopathies, I will still use autologous blood, which is going way back to the original training I did with you before, you know, we really got into PRP, because you don't want to create a huge, well, you want to create an inflammatory response there, whereas with articular, intra-articular joint work, you don't want to have that inflammatory response. So I'll sometimes use autologous blood, but I use the Dr. PRP. Sometimes I will just use a tube if it's actually just going into a, for PRP, just into a very small area of tendinopathy or soft tissue injury. So I will do that, but I tend to use the Dr. PRP, which is a closed kit.
Yeah.
Very similar to the lavender, I know that you're using.
There are several good kits out there and good tubes. And as you say, autologous blood, using somebody's own blood, taking a sample of their own blood, and then re-injecting that can be quite useful in certain instances.
Oh, it works really well. It does work really well, particularly for things like Achilles tendinopathy, epicondylitis. It works very well.
I suppose really that goes back to what we were talking about the concentration of vascular endothelial growth factor, because if you're doing it into a tendon, and if you up the vascular endothelial growth factor, then you could promote angiogenesis into the tendon, couldn't you? Which, I mean, we see that, don't we? When we ultrasound something, we see these little speckles on it that are little blood vessels trying to invade the tendon, which can cause all sorts of...
And also, not forgetting the fact that you're sort of peppering, using a needle anyway, so you're automatically creating trauma, again, which is creating this whole cytokine inflammatory and this whole healing cascade. So you're getting like a twofold effect. Yeah. So it can be quite expensive, PRP. So, in times for patients who actually have soft tissue injuries, I will tend to use either a cheaper option, which tends to be just blood.
Yeah, their own blood. And of course, it is recognised by NICE, isn't it? Autologous blood.
Again, loads and loads of research out there, particularly for epicondylitis and Achilles tendinopathies, and works really well.
All right. Yeah. So the next time I get lateral epicondylitis, you'll be able to come and see you.
Work really well.
with my tennis elbow. Okay.
Yeah, it does. Sorry, Martin. It does seem to work quite well with in orthopedics anyway, as some of those research papers show. And I have heard of good success with cruciates and knee injuries, particularly in sports people anyway. So it has a modification, can't say it today, a modicum of success in those areas. Coming back to the point that Gaynor made, we had somebody said that in Bangladesh, using plasma for COVID-19 patients is being trialled and seems to be working good so far. And there's also, there is a dependency on leukocyte rich or poor, and again, dependent on the area of injection. So that's a couple of the comments that have just come up on the chat as well.
Indeed. And also there's an idea now of using platelet plasma as well, isn't there? In certain instances. I mean, I know from the early days they were using this in some dentistry, some maxillofacial surgery applications, where what they would actually do is they'd take the platelet-rich plasma and then they'd spin it up again, and they'd make literally a clot, a fibrin-rich matrix that they would use to replace little bits of bone, in the jaw, in maxillofacial work. So it's got multiple applications. It's a very interesting area to look at.
And wound care as well, injecting around those wounds, because I know we shared some information about that, Martin. So injecting around non-healing ulcers have had great success for improving blood flow, you know, the whole of that, you know, promoting a whole healing cascade within a wound that just won't heal for, well, possibly, you know, a year plus. Had some great results with people with diabetes.
Excellent.
Gina and Martin, have you had any success with arthritic joints as well, using PRP or prolotherapy, as opposed to steroid injections?
Well, I mean, steroid injections are, at the moment anyway, contraindicated because they depress your immune system. So there's a lot of information going on around that. But my own personal thing is I tend to use prolotherapy more. And we'll talk about prolotherapy in a minute. But I tend to use prolotherapy more if I'm going intra-articular. How about you, Gaynor?
With intra-articular, I tend to use platelet poor plasma in conjunction with the hyaluronic acid, because they work really well together. There's some really good research too on that. So, but prolotherapy, yes, I'm not an independent prescriber, Martin, so I tend to struggle a little bit more with using prolotherapy with dextrose and whatever.
So when are you going to do the course, Gaynor?
I really want to. Martin, tell me about the institute. What is happening? Mind you, nothing's happening at the moment, is it? But I really want to do the independent prescribing. Can't get mentors. It's just gone for years and years.
But I'm perfectly happy to mentor you. Bear in mind that the legislation changed at the end of last year.
Yes,
Now, up until the end of last year, your mentor had to be a medical doctor.
Yeah.
Now, way back in 2010, 2011, when I was on the NHS, well, not the NHS, Department of Health independent prescribing group, what we had to do in order to get independent prescribing through for podiatrists, we had to agree to our mentors being medical doctors, otherwise they would have just blocked it. They weren't very happy about it anyway. And perhaps some doctors, if there's any doctors watching, then I'm sorry, but the fact remains that a lot of medicine doesn't like independent prescribing podiatrists or any other kind of independent prescriber, because if I hang a stethoscope around my neck and I've got a prescription pad in one hand and I'm doing all sorts of things to a person, then the boundaries kind of between being a doctor and then being a fake chiropodist with attitude, the boundaries kind of blur a bit. But that changed then eventually. I mean, that was our goal all the way through the last decade, was to get that changed, and changed it has been. So your mentor can either be an independent prescribing podiatrist, it can be a nurse independent prescriber, any appropriate prescriber that's accepted by that university. It's a 6-month course, as you know, it's a part-time course. Then fine, so you don't need to source a doctor, and that's been the sticking point over the last decade, but that doesn't apply now. So look, you've got no excuses now whatsoever, Gaynor. I've made the offer, look, in public.
Perfect. Well, I'm really hoping that Birmingham, is there any more information about the liaising with Birmingham University?
Yeah, just send your application and I'll give you a link up there. Yeah.
That sounds great.
Come to Brum.
Brilliant. Beverly?
Yeah, that sounds good for me too. Yeah.
Go for it.
To mentor, Martin.
Yeah, I don't mind. Right, shall we get back to prolotherapy? Because you see, you need to be an independent prescriber for this, or have a relationship, and I'm talking about a proper relationship, not an improper relationship, have a proper relationship with a prescriber who will prescribe this stuff, which is perfectly legal, provided the prescribing is done in a legal fashion, and so on and so forth. Prolotherapy basically also drives healing, but it drives it in a slightly different way. Now, if we look at dear old Hippocrates, I knew him well as a boy, and he said this in his writings on the articulations, that it deserves to be shown how he treats a shoulder. Now, of course, back in the days of ancient Greece and all the rest of it, I think they spent a lot of time hurling javelins around and doing things like that. So very often in the games that they had and all the rest of it, these javelin throwers would, hurt their shoulder, they'd dislocate the shoulder and things like that, or they might dislocate the shoulder while they're doing sword fights in battle. And they'd come along to dear old Hippocrates and say, well, you know, look, doc, can you do something with my shoulder? It's kind of hanging down like that. Then what he would do is he'd take one of those little gadgets on the right-hand side of my screen, which I assume is also on your screen as well. And it's like an iron needle. And those are called cauterions. Now you can see where the root of the word cautery that we use nowadays came from. What you do is you'd stick those in the fire until they were red hot, and then you'd take it out and you'd plunge it repeatedly through the area of damaged ligaments and tendons to, as Hippocrates says, brace up the shoulder. And the idea was that it would stimulate a healing cascade in that area. It would stimulate the production of collagen as part of the process of making scar tissue and all the other things. And it would, you know, tighten the shoulders up. So they'd walk out there, you know, with smoking shoulders saying, thank you very much, doc, you know, I'm really braced up now, I'm all right. Go back to hurling the javelins. I must admit, I've never tried that myself because I can't get a patient to volunteer for it. We might one day put a training course on Cauterians on in the Institute. You never know. Never say never.
No, Martin, I was just going to say that acupuncture, I think, is about the closest we're going to get to that.
Yeah,
So,
acupuncture, it's a little gentler, isn't it, than that?
Yeah.
But I would imagine that that is very satisfying to thrust a red hot cautery through somebody's foot, for example. I mean,
Depends
obviously
on
we
your
don't use
nerves
feet.
and if you want to play Jesus.
No,
Especially
probably
through
not.
the foot. Martin, sorry, I want to go back quickly before we lose the thread here a bit. Going back to the question regarding what Gaynor was talking about, PRP and hydroloric acid injections in conjunction with each other. We just had someone who hadn't heard about that and wanted to make sure that that is what you mentioned.
Yeah, that's what I mentioned.
Yeah,
Yeah,
basically, yeah. Combinations.
Yeah.
There's some good studies out there too, and I've also had a combination. I've used that with patients. It works very well together. Some good research out there.
Yeah.
And of course, essentially what you're doing there as well, it's worth mentioning for any members of the Medicines and Healthcare Products Regulation Agency listening, that you're not combining two medicines to make a medicine there. You're combining two things that are not medicines. Whereas if you were mixing medicines, that's something different.
Yeah.
I mean, as we know, technically, you should not mix a medicine unless you are able to prescribe medicines. So the people who are mixing various types of anesthetics, for example, using an exemption under the POM-A, then technically they're breaking the law.
Yeah.
But when you're mixing things that aren't medicines, then that doesn't apply. So yeah, you can mix those because the medical devices are once an autologous fluid. Anyway, so we've got old Hippocrates with his smoking cauterion. We need to move forward a little bit now to the 1930s, because the basic concept that Hippocrates had of irritating tissue or stimulating a reaction in tissue by doing something was picked up by Rice, Aronson, Lariche, a few people like that, a few researchers like that. And they looked at the concept of injecting with a hypodermic and irritating solution into a damaged ligament, for example, with the aim of producing fibrosis around that. So strengthening it up, bracing it up, as Hippocrates would have said. And that was based on the idea of sclerotherapy. Now, as we know, with sclerotherapy, if you look at it in a venous situation, treating a vein, then you would actually extravasate the blood. You'd squeeze the blood out of the vein, and you'd inject it with some kind of substance that would cause scarring inside the vein. It would become the basis of the scar tissue in the vein and block it off. So you're getting rid of that varicose vein by doing that. And that's the basic principle of sclerotherapy. Scleros, of course, is Latin for scar. So essentially you're promoting scar tissue inside the vein. But they looked at using things that were slightly gentler than that. They weren't trying to destroy tissue predominantly, but they were promoting a response. So that essentially it was sclerotherapy in tissue as opposed to in a vein.
Martin, you've frozen.
Yeah.
It's nice, but I think you're pressing a button and it's all gone mad. Hello, Martin.
Well, I can hear you, Bev, but that's all. Martin's definitely frozen there.
Yeah. He's gone.
Should we send him a little chat?
Yeah.
I'll send him a chat.
I don't know if he'll be able to see it, but
Yeah, that's a good point.
yeah, he'll be back in a minute. I think he's just, yeah, problems with technology, as we do. So
He's talking away.
is he? I can't see that bit.
I can see him talking.
Hello, Mother. Can you hear me?
Yes.
Good.
You're back.
No.
Did someone plug you in?
No, my internet just dropped out. I mean, this is the disadvantage of living in deepest darkness. You know, probably a sheep nibbled the phone line or something. All sorts of things happen. It's always very challenging around here. If you're not being arrested by the police for leaving lockdown, then the sheep are attacking your telephone lines. So, right, I'm back. So we've mentioned risenarotsen and so on and so forth, and they looked at using a sclerosing solution into damaged ligaments to try and brace that ligament, which was quite interesting. And sclerotherapy became popular for a few years. There obviously are some downsides with that, because some of the substances that you use for sclerotherapy, phenol, sodium tetradecyl sulfate, polydocanol, all of those, they're quite caustic and corrosive things, and they can actually cause quite a bit of damage. So along came a chap called George Stuart Hackett, MD, and he was an American doctor, and he experimented with the principle of risenarotsen, so injecting something in there to provoke a healing response to get, for example, those fibroblasts making this collagen and what have you to repair that ligament. And he looked at using gentler substances, and he published, I mean, he did his research in the early part of the 1950s, but he published in 1956, and he published on ligament and tendon relaxation treated by prolotherapy. So once again, this idea of bracing up a loose ligament, bracing up a tendon. So if you've got loose ligaments around a knee, for example, then that interferes with the function of the joint.
Martin?
Yes?
So could you screen share as well, because we've all lost the
oh, right, okay.
The slideshow there.
Oh dear, sorry. Right,
thanks, Caroline. Can I just also interject? We've had a message saying that if we can't get POM for prolotherapy, there are some other alternatives such as Tramil or Zeal.
There are alternatives. I mean, obviously, you know, within the format of what we're doing here, we can't really look at every opportunity. So all I'm going to do here is concentrate on, you know, on the traditional stuff. And I'm also, so can I share my screen with you? Are you seeing my screen, Bev?
No, not yet.
Right. Okay. So what are you actually seeing?
Your beautiful face on Frozen.
My God, you poor people.
You're not in Frozen 3 now.
You poor souls. Right, let me try again. Right, about the only thing I've been able to do is, let me try again. Right, can you see my screen now?
Yeah, it's starting to come out. Yeah.
Ah.
That's it.
Perfect.
Okay.
Yeah.
So we're still seeing forward to the 1930s.
Absolutely.
Good. Okay. So let's come along now to the 1950s. And as I said, George Hackett, MD, an American doctor, and his research is he published on using a gentler solution to treat relaxed tendons and ligaments, as he called them. So these are things that would have been sprained and strained as opposed to ruptured. I mean, if you've got a ruptured tendon, then no amount of prolotherapy will probably help it. But if you've got something that's undergone a plastic change as a result of excess tension being applied to it, then you can tighten that up again, and you can make a joint, the joint that serves, you can tighten the joint up a bit. You can brace it. And of course, the more congruent a joint is, then the better its function. You know, so you tighten up the ligaments around it. And what he looked at was using hyperosmolar substances, sometimes called osmotic shock agents. And these are things that invariably were mixed with a local anesthetic. In his days, lidocaine, or nowadays we use a variety of different local anesthetics that we can use. And he used glucose. Some people just use saline. Some people just use local anesthetic. But what Hackett was talking about was glucose. He was talking about glucose, or dextrose as he called it, dextrose and lidocaine prolotherapy. And that's something that he developed over a number of years. As I say, he published in the 50s. And nowadays you'll find it's a very popular therapy in America. You've got companies like Caring Medical. If you go on the web and look at Caring Medical, you see they do thousands of procedures. But other people building on Hackett's idea of using an irritating agent. Some of them have used saline. I mean, there's a doctor in New Zealand, Girish Kenji. He just uses saline to inject an area of damage. And very possibly, as Gaynor mentioned earlier, probably a large proportion of the body's response to that is a response to the fact you're sticking a needle in. So akin really to this idea of Faulkner's needling with a verruca, isn't it? You stimulate a healing response with a needle. But saline, as I say, is his popular thing. Local analgesics, our very own Dean of Podiatric Surgery in the Institute, Bill Liggins, he published, I think it was in the 1970s, possibly 1980s, when he was a consultant at Solihull, or Heartlands, as I think it's called now. So he was a consultant podiatric surgeon there. He's only just retired, and as I say now, is our Dean of Podiatric Surgery. And working with his registrar at the time, Julian Pavia, they looked at simply using local analgesics, local anesthetics, specific to treat heel spur syndrome. So repeatedly injecting Marcaine, I think they used. Once again, the needling itself probably had a big component of that. Other people have used mannitol, which is a kind of sugar. Other people have used sodium bicarbonate. Because sodium bicarbonate, there's the potentials there for things to go dramatically wrong if they're using too much of it, because obviously the sodium in it can upset the fluid balance of the body, which really is designed to do, I suppose. But mannitol is quite interesting because mannitol is a sugary substance, essentially. And now, if you look at Ostanil plus hyaluronic acid injection, they put mannitol in it. So really, it's almost a prolotherapy solution in its own right. And I've often wondered, apropos of that, whether it would be interesting to try that as a prolotherapy agent in tendons, for example, around the area, not in the traditional way, but actually into the tissue surrounding it, per ligaments and things like that. Might be interesting to look at. But the idea of these substances is that they place a cell under stress without destroying it. Sclerotherapy destroys cells. If you're going to inject strong agents into it to cause scarring, then you're going to kill some cells. Now, obviously, as they're dying, they'll probably be sending out cytokine messengers. But the idea is with prolotherapy that you're using something that simply puts a cell under stress. And a cell under stress will also make growth factors. It will also produce growth factors to recruit the healing response. And that's the idea, essentially, behind prolotherapy. So it's a very, very simple concept. You can't actually make it more complicated than it is. As I say, you simply need the ability to use this stuff. And obviously, some of it, you need to be a prescriber for, but you don't need to be a prescriber for local anesthetics if you've got POM administration, do you? You can actually use that. and needle it with Marcaine, for example, which is on your exemption list as a podiatrist if you've got POMA. So that, that covered, I think, the basic ideas behind these two therapies. I'm just making the point there that sclerosing agents cause quite a bit of destruction, whereas prolotherapy action agents just make them unhappy. So you make a cell unhappy, and an unhappy cell is a cell that makes cytokine in revenge. How safe is it? Well, Tom Dorman, who was a doctor in America, but he trained in this country. He was a Brit. Unfortunately, no longer with us now. He passed away a few years ago. But he did he was a prolotherapist, a really keen prolotherapist, and he did that huge survey of prolotherapy from the safety point of view. And as you can see, apart from some claimed, look at the size of that sample. You know, 500,000 people we're approaching there. There were 24 reported allergic reactions, if there were allergic reactions or not. I mean, they could have been to perhaps inappropriately injecting the local anesthetic into a vein or an artery. 29 cases of pneumothorax. You know, now obviously as podiatrists, we don't inject the chest yet. I have no intention of provoking pneumothorax in people. But the rest of it, very, very high safety record. I've personally, and I'm touching wood for all I'm worth now, in more than a decade, well more than a decade of doing prolotherapy, I've never had an adverse reaction. Have you had any, Gaynor?
Probably just in sort of quite an inflammatory reaction, but that's to be expected really. So just you advise patients to possibly ice the area, but I've never had an overreaction.
No, same here. And I mean, this is one of my go-to things. So there we go. Essentially, folks, that has explained the difference, I hope, in my halting and rabbiting on way. That's explained the difference, hopefully, between platelet-rich plasma and prolotherapy. And
with the prolotherapy, Martin, as well. I mean, I used to use an awful lot of neural prolotherapy to try and, which is very, very shallow treatment rather than a deeper treatment. So to try and a very, very small amount when I could get glucose, can't get it now, off because I'm not an independent prescriber. You could actually, you used to be able to get it from GP supplies quite easily. And a very, very tiny amount of glucose to block the neural pathways because people get stuck in this pain cycle. And if you can stop that pain cycle very often, and that's why just possibly injecting an LA would also do that too, because you are just disrupting that whole pain cycle, because people's bodies do tend to replicate and just get stuck in that whole pain cycle. It sometimes needs to be stopped to move forward, the patient forward into repair and healing. So neural prolotherapy works quite well and very safe because it's tiny amounts of.
Indeed. I mean, it just demonstrates, I think, that as a profession, that we have access, whether we're prescribers or not. I mean, if you've got a POMA, you've got access to some very powerful medicines that very often are underused, aren't they? We tend to underuse local anesthetics in podiatry to a great extent, because there are many things, as you quite rightly say, that they can be used for. You know. Okay, well, that's pretty much I've got to say, and that's brought us to 12 o'clock when we're due to finish. I hope it's been of interest to a few people. Would any of the panel like to add anything? I mean, you know, thank you for what you added, Gaynor. Anybody else want to make a point?
When's it going to be available for your face?
Yeah.
I'm in need. The collagen.
Unfortunately, I'm only insured up to your knee, so I can give you beautiful calves, face. It doesn't need anything doing anyway. It's me that needs the stuff.
No. But does it count that I usually have my foot in my mouth? So perhaps.
Not at all.
Jokingly, of course, but
not at all.
The stupidity of stuff that comes out of my mouth. So yeah, it might just keep it together. I don't know. No, I can't. I'm not going to go there. I'm going to grow old gracefully and give my feet the prolotherapy treatment and let them look young all the time.
And why not? That's a good reason.
Pain-free.
Pain-free.
I think
Well,
I'm sorry, Party. Before we go, Bev mentioned about Zealand Traumeel and other homotoxic medications, and I think it is really worth people knowing about those substances because they are available and actually they do work very, very well. I think it was Somas that mentioned about the Traumeel and the Zeal. They do work very well. I do use an awful lot of those substances, certainly intra-articularly I do, because they're very safe. They are saline too, so you're getting the biotherapeutic medication, and you're also getting a slight irritant as well with the saline. So, and I mean, they work very well. They do work well and are very safe.
The company that does those is a company called Biopathica, P-A-T-H-I-C-A, Biopathica. If you go on the internet, you'll see their website.
They are, and they're so approachable. Craig is lovely. There's lots and lots of information online about Zealand Traumeel too.
Once again, obviously, you have to have done a training course in these things before they will supply you. They need evidence of your training.
They do. Yes, they
but
do.
if you've had the training, then yes, they will supply you. And yeah, as you say, a very good company. Very good company. Okay, well, I'm going to go and get a cheese sandwich now, I think.
Enjoy.
Thank you ever so much, everybody, for taking the interest to listen.
Yeah, thanks, everybody.
If you've got any particular queries that you want to send into head office, then please do so. You know, we're always happy to hear from people. And I'll just close by saying thank you very much indeed. Stay safe, people. Stay safe.
Yeah.
Thank you, Martin. Yeah.
Okay.
Thank you, Martin.
All the best.
Bye to everyone.
Bye to everyone.
Bye.
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 Bye.